Hello everyone, this is our next Radnomics interesting case. This week we have a 70-year-old male patient presenting with bilateral flank pain and jaundice, and maybe some slightly deranged liver function tests. We've got some images here, some axial images from what looks like a delayed phase post-contrast CT of the abdomen and pelvis. And when thinking about a patient with back pain, I guess the first thing we can see is there's some mild prominence of bilateral renal pelvises and maybe the proximal ureters as well. As we follow the proximal ureters down, seen nicely and full of contrast, easy to spot, we can see that they are drawn medially. So scrolling up, start laterally, and they're both drawn medially towards and really enveloped by this soft tissue mass, quite ill-defined soft tissue mass surrounding the abdominal aorta. The mass continues all the way down past the level of the aortic bifurcation and down both common iliacs, and even down further towards the pelvic sidewall. The mass is quite irregular, as we spoke about. We can see it kind of plasters the aorta down onto the vertebral body sitting behind it. It doesn't really lift the aorta away from the vertebral body. And when we follow it up, it probably continues up to really kind of maybe just below the level where the renal arteries come out. So it's kind of that level and below. Now we've got to think about this patient's other presenting complaint here really, and that was this jaundice. And when we come up and look at the liver, we can see that there is prominence of the intrahepatic biliary tree. Perhaps not gross dilatation, but certainly a prominent looking CBD here seen at the liver hilum. And then as we come down to the pancreatic head, we can see the CBD seems to smoothly taper down towards the level of the pancreatic head. Looking at the pancreas, it looks a bit bulky. It doesn't have the usual kind of cloud-like margin at its edges. It has a very smooth, quite crisply defined margin here. So, and then looking at the rest of the abdomen, I mean, the kidneys themselves, there's no concerning renal lesion there. The bowel looks normal. Can't see any other abnormalities, and the lung bases are clear. So let's try and put this into a report. Ill-defined periaortic mass. The mass extends from beyond the aortic and to the iliac bifurcation. What else could we say? So that describes the mass a little bit, and I think the mass looks like it's kind of mildly enhancing. You have to trust me if we compare this to non-enhanced images, which we'd see a little bit of enhancement on these delayed phase images. So mild enhancement on the delayed phase images. What else should we mention about this? Let's think. So let's talk about liver. Mild intrahepatic dilatation, smoothly. Let's say CD smoothly tapers. Pancreatic head, smooth and swollen appearance of pancreas. And then we can probably say otherwise normal. I guess the important thing to mention is that there are no radiobate gallstones. Cool. So let's have a think. Yeah, let's see what report we can generate here. And in the meantime, I think it'd be nice to have a think about what's causing this. We've clearly got some kind of slightly unusual findings here, and I wonder whether there could be some kind of diagnosis that links all of these things together. So let's have a think. Does any diagnosis link the periaortic and pancreatic appearances? Okay, so we've got a suggestion here, and it's suggesting that we think about a process within the spectrum of IgG4 related disease. IgG4 can present with autoimmune pancreatitis and can cause this kind of sausage-shaped pancreas appearance, and then also can be associated with retroperitoneal fibrosis, which could really nicely explain what we're seeing here around the aorta with the kind of classic plastered down appearance of the aorta and medialized ureters. So I think that could be something worth suggesting. Why don't we see just make sure we're not missing something here. If this is a kind of multi-system process, we want to make sure we've looked for all the possible reasons. So yeah, sclerosing cholangitis. I mean, maybe we do have an element of sclerosing cholangitis here. Maybe that's what's causing the tapering of the pancreatic, of the common bile duct. Gallbladder involvement. The gallbladder looks normal here, so that's nice. Renal involvement. I can't see any concerning focal renal lesion. There's a couple of cysts, but nothing concerning there. And then mesenteric or mental involvement. Yeah, I did, when scrolling through, spot a small area here where you can see, looks like extension of the soft tissue along mesenteric vascular branches here. So that could be a degree of mesenteric involvement. And it looked continuous with the periaortic disease. And then lymphadenopathy, it'd be worth having a look for lymphadenopathy. I didn't spot anything on our first roll through, but there are a few small nodes, but nothing particularly impressive. Perhaps some very high nodes there. Okay, so that's interesting. That gave us some kind of review areas to look at, and maybe we could mention there's a bit of mesenteric disease. So let's see what report we've got here. Yeah, comparisons made. That's fine. New pages, yeah. Other than report. That's good. Yeah. It's good. Yeah, so it's made a bit of an impression there, but now we've learned a little bit from our interaction with RadChat. We could probably write something a little bit more succinct. Overall appearances for systemic IgG for disease with associated retroperitoneal fibrosis and autoimmune pancreatitis. The patients be arranged. These may be due to a degree of IgG4 cholangitis and back pain, or it was flank pain, wasn't it? Flank pain could be the result of of mild nephrosis, and then maybe we should say something advise referral to the urology and gastro and urology teams for management and further. Okay, let's finish with that.